Hello and welcome to your Smoking in Pregnancy session for the Saving Babies Live Study Day. My name is Kaya Rothman and I am a smoking cessation lead midwife for the Norfolk and Waveney LMNS based at Norfolk and Norwich University Hospital. Our learning objectives for this session are to understand the national and local context of smoking in pregnancy, understand the pathophysiology and risks of smoking during pregnancy, feel confident in offering very brief advice, referring pregnant women and their partners to stop smoking services, using a carbon monoxide monitor, promoting smoke-free homes, and giving advice regarding vapes and nicotine replacement therapy. This session has been included in the Saving Babies Lives Study Day to address Element 1 of the Saving Babies Lives Care Bundle, which calls for urgent action to increase the number of smoke-free pregnancies. Our work sits firmly within the LMNS prevention workstream for the Maternity Transformation Programme, and the Department of Health has set a national ambition to reduce the prevalence of smoking in pregnancy to less than 6%. In commitment to this, the East of England Maternity and Neonatal Safety Improvement Programme has selected smoking in pregnancy as their focus for the next year. Norfolk and Waveney's smoking at time of delivery rate is currently 14%, which is well above the national average of 9.9%. Our latest LMNS dashboard has shown that there is a high degree of variation in the SATOD rates between the acute trusts in Norfolk and Waveney, with rates of 11.7 for Norfolk and Norwich University Hospital, 16.6 for Queen Elizabeth Hospital, and 17.3 for James Paget University Hospital. The graph on the right-hand side of the screen has been taken from NHS Digital. The thick blue line represents our SATOD rate for the last 7 years, in which a slight decrease can be noted, and this mirrors the national trend of SATOD rates. The dotted line across the graph represents the national ambition, so as you can see, we still have a lot of work to do before we reach that target. To understand the pathophysiology of smoking in pregnancy, I thought we would watch a short video which is available on the Tommy's website. This video is a really good resource to signpost women to and their partners so that they can see how the chemicals from cigarette smoke flow through to the baby. So there are over 4,000 chemicals in cigarette smoke, including nicotine, carbon monoxide, carcinogens, and heavy metals. Carbon monoxide is particularly dangerous as it rapidly binds to hemoglobin to form carboxyhemoglobin, which it significantly impairs the delivery of oxygen to the fetus, and in turn negatively impacts on the growth and development. Risks of smoking in pregnancy to the baby includes stillbirth, miscarriage, fetal abnormalities, low birth weight, and neonatal admission to NICU. Women who smoke 10 or more a day are 52% more likely to suffer a miscarriage, and 1 in 5 babies who are born to mothers who smoke have a low birth weight. Risks of smoking in pregnancy for the mother includes ectopic pregnancy, antepartum hemorrhage, blood clots, postpartum hemorrhage, as well as other associated diseases such as cancer, heart disease, and COPD. Smoking during pregnancy causes up to 2,200 premature births, 5,000 miscarriages, and 300 perinatal deaths a year in the UK. NICE guidelines recommend that all pregnant women are asked about their smoking status at booking and confirmed via CO monitoring. CO testing was paused in March 2020 in light of the coronavirus pandemic. However, Public Health England are now recommending that CO monitoring can be resumed at antenatal appointments following in-depth research regarding the transmission of COVID-19. The manufacturers of our carbon monoxide monitors have undertaken assessments to ensure that the viral filtration is adequate to safeguard against COVID-19 transmission. Therefore, CO monitoring should be performed at every antenatal contact. It's important to remember that women who are exclusively vaping are classified as non-smokers, and women who have quit smoking for 2 weeks or less should be referred to stop smoking services. Here is a short video which demonstrates how to use a carbon monoxide monitor. This has been produced by Bedfont, who are the manufacturers for the carbon monoxide monitors that we use.
Carbon monoxide is known as the silent killer because it is an invisible, tasteless, and odourless gas that is formed from incomplete combustion, such as house fires, car exhaust fumes, and smoking. Oxygen is carried around the body by red blood cells, and when you inhale smoke from a cigarette, the CO is absorbed into your blood through the lungs. Because CO binds with hemoglobin 200 times more readily than oxygen, your body is starved from oxygen. This leads to many health complications and smoking-related diseases, such as a higher risk of stroke or heart attack, shortness of breath, and poor circulation. The Pico Baby Smokeryzer has been specifically designed for midwives to help mums-to-be quit smoking. It works by non-invasively measuring carbon monoxide on a smoker's breath and also calculate the amount of CO that is affecting the unborn baby. To take a maternity breath test with the Pico Baby Smokeryzer, first attach the D-piece to the monitor and then the SteriBreath to the Pico Baby. Click on the maternity breath test icon to begin. You will be asked to inhale and hold your breath for the preset 15-second countdown before slowly blowing into the Pico Baby. The reading will rise and stabilize on screen, and you can choose to mute the monitor if necessary. Here, you will also see the fetal carboxyhemoglobin calculation, which is the amount of harmful CO affecting the unborn baby. When the test is finished, click the home icon to return to the home screen. Readings and results can be interpreted using the Maternity Smokeryzer CO chart.
Once the carbon monoxide testing has been performed, a reading will be displayed on the screen. If the reading is less than 4 parts per million and she does not smoke, then no further action is required. If the reading is 4 parts per million or more and she reports to smoke, then we must refer her to Smoke Free Norfolk. If she reports that she does not smoke, it's important to discuss environmental carbon monoxide inhalation, such as faulty boilers and secondhand smoke. If the reading is 10 parts per million or more, and she reports to smoke, then she must be referred to Smoke Free Norfolk. If she does not smoke, we must refer her to A&E for a medical review and advise her regarding carbon monoxide poisoning. We must give her the number for the Health and Safety Executive Gas Safety Line of 0800 300 363 so that they can test her boiler to ensure that it's working adequately. Very Brief Advice is an evidence-based intervention designed to increase quit attempts among people who smoke. It takes 30 seconds to deliver and follows the format of Ask, Advise and Act. Here is an example of dialogue to use. For step 1, Ask, is to identify smoking status by performing carbon monoxide testing and simply asking, do you or anyone in your household smoke? For step 2, Advise, we need to discuss the risk of carbon monoxide and smoking in pregnancy by saying, carbon monoxide is a highly toxic gas that can impact on the growth and development of babies and increases the risk of miscarriage. We know that women are much more likely to quit with the help of specialist services. Step 3 is to act. This is to refer women to Smoke Free Norfolk on an opt-out basis by saying, "It is our standard practice to refer all women who smoke to Smoke Free Norfolk. They will call you and have a quick chat to see if they can offer you any support." Very brief advice is a feasible and acceptable method of smoking cessation support in which 30 seconds of conversation has the potential to save a life. NICE Guidelines recommends that we refer all women who smoke during pregnancy to the Stop Smoking services on an opt-out basis. This means referring automatically unless they openly object. This means that we are affording all pregnant women who smoke the opportunity to access specialist support and may improve cessation outcomes. Referrals must be extended to partners or household members who smoke as part of our initiative to increase smoke-free homes. Referrals can be made to Smoke Free Norfolk via telephone on 0800 0845 4113 or alternatively on ICE under the heading Services. It is also very important that we commence pregnant women who smoke on the fetal growth scan pathway. Although we do not have evidence that vapes and e-cigarettes are 100% safe during pregnancy, we do know that they are a lot safer than smoking. Vapes contain approximately 10 to 20 chemicals rather than 4,000 found in cigarettes, and vapes do not contain any carbon monoxide. Furthermore, there is no evidence of harm to others from vapes, unlike secondhand smoke. And if a woman exclusively vapes for 2 weeks or more, she is classified as a non-smoker, so please be cautious of this when entering the smoking status at time of delivery. Nicotine replacement therapy may be used by pregnant women if it helps them to stop smoking. Nicotine replacement therapy only contains nicotine and none of the other chemicals found in cigarette smoke, such as carbon monoxide. NRT products include short-acting NRT, such as gum and nasal spray, which delivers a swift dose of nicotine to combat intense cravings. And there is also long-acting NRT in the form of patches, which delivers a steady stream of nicotine throughout the day. Research suggests that using short-acting and long-acting NRT together is the best method to avoid relapse to smoking. Patches should be worn for a maximum of 16 hours a day during pregnancy and should be removed at night. Also, licorice-flavoured NRT products should be avoided, which is based on information about the adverse effects associated to licorice root. Exposure to second-hand smoke is a major cause of childhood illness and costs the NHS £12 million a year. It is a major risk factor for the development of the heart and respiratory conditions, as well as significantly increasing the risk of sudden infant death. Women who quit during pregnancy are much more likely to relapse if they live in a household of smokers. That's why it's essential to extend stop smoking referrals to partners or household members who smoke. If a woman and partner continue to smoke after baby's arrival, then we need to encourage them to smoke outside and away from the baby. Remove the clothes that they have been smoking in and wash their hands before handling baby. Furthermore, children who grow up in a household of smokers are much more likely to smoke themselves, and therefore the cycle is perpetuated. Ongoing care for women who smoke in pregnancy. Carbon monoxide should be performed at every antenatal contact for every pregnant woman. If the woman is a confirmed smoker, CO readings can be a source of motivation to quit, and a normal carbon monoxide reading would be very rewarding. Furthermore, it is important to remember that CO testing is not only used to screen women who smoke, it is also used to screen for environmental carbon monoxide inhalation, such as faulty boilers, which is why we must offer it to all women throughout their pregnancy. Women should be commenced on the smoking in pregnancy scan pathway to observe the growth and development of the baby. We should continue to offer referral to women and their partners who initially declined. We need to be able to identify relapse following a quit attempt and encourage her to engage with Smoke Free Norfolk. And we must be proactive in promoting smoke-free homes. The future of smoking cessation support in Norfolk and Waveney. We will be recruiting smoke-free pregnancy champions for each continuity of care team and in each of the clinical areas. They will act as a link between the teams and the smoking cessation lead midwives to help deliver initiatives and support their colleagues in giving smoking cessation advice. We are introducing instant access to nicotine replacement therapy for pregnant inpatients. This means that all pregnant women who smoke will be offered NRT if they are admitted to hospital. The Medicines Administration policy for midwives has been amended to include nicotine replacement therapy products, so midwives will be able to prescribe the first dose of NRT after they have undertaken the appropriate training. This will be launched in the antenatal wards first over the next couple of weeks. The Maternity and Neonatal Safety Improvement Programme are also trialling personal carbon monoxide monitors, whereby women will have their own carbon monoxide monitor to plug into their phone to track their CO readings. This has been very, very positive in Greater Manchester, and we're hoping to replicate similar results here so that it can be implemented throughout Norfolk and Waveney. This is being trialled at West Suffolk Hospital. So the take-home messages of this session are: reducing smoking in pregnancy is a significant factor to saving babies' lives. All women who smoke in pregnancy should be referred to Smoke Free Norfolk on an opt-out basis. Vaping and e-cigarettes are safer than smoking normal cigarettes and therefore can be recommended. Women who exclusively vape are classified as non-smokers. And we must promote smoke-free homes and offer partners referral to Smoke Free Norfolk. That concludes your Smoking in Pregnancy study session. If you have any questions related to smoking in pregnancy, then please contact the Smoking Cessation Lead Midwife for your area using the email addresses on the screen. Thank you.